Thank you for having us here. So yes, potential tools for the prevention, diagnosis, and personalized treatment of chronic pain. Question mark. So you see there's a bit of wishful thinking about what we could do with a number of non-invasive measures of nociceptive processing that we can get in humans. So this is a bit what I'm going to talk about today. And it's basically about what can be done with human biomarkers of nociceptive processing. And I will explain a bit what I mean by that later on, the different tools that we have. Lisbeth was explaining the importance of the context of the system, and actually those markers try to get a glimpse, a bit of an understanding of the context in healthy volunteers. And I will show you some models where we can actually try to change the context in healthy volunteers to obtain a context that might mimic the context we can see in patients. So obviously, yes, biomarkers of nociceptive processing, so to obtain measures of nociceptive processing in humans is important to try to understand nociception and pain, and so to explore nociceptive processing in humans and its modulation, and this is basically the core of what we do in our lab. But today I will focus more on potential applications of those biomarkers for the treatment of pain. So one of them is actually very closely related to the presentation of Lisbeth, is to try to use some of those non-invasive measures of nociceptive processing, direct or indirect measures, to try to use them as pharmacodynamic biomarkers to try to evaluate in humans, to evaluate target engagement in early stage clinical trials. And then I will move on to other potential applications, clinical diagnosis and personalized medicine. There is one application of such biomarkers which is already clearly established. It's for the diagnosis of neuropathic pain. I will discuss that a bit later on. And then there is the potential to move forward for more mechanism-based diagnosis, really looking at the mechanisms underlying some chronic pain conditions, to maybe offer opportunities also for patient selection, so patient stratification and predicting response to treatment. And then I will end my talk with the potential use of biomarker also maybe to prevent chronic pain in some conditions, to identify maybe patients that are more at risk of developing a chronic pain condition. And you will see that this is really, I would say, the beginning. For the moment is more possibilities that it might actually be possible to identify, for example, patients that have a higher susceptibility to develop chronic pain, or also for the early diagnosis of neuropathic pain. For example, I'm thinking of diabetes and small fiber neuropathy, where you might, if you can identify it early before symptoms appear, there might be a window for preventive treatments. But if I come back now to first as tools for pharmacological development and the use of pharmacodynamic biomarkers. So if we look at the classical linear pipeline for drug development, which starts with preclinical and animal studies, where we try to understand the physiology and pathophysiology, we try to identify new pharmacological targets, to identify new compounds, and then once we've identified an interesting target and an interesting compound, we can move then to human studies. And there is the question of the translation that was also discussed in the previous talk. And typically we would start with studies in healthy human volunteers, studies like Geert-Jan, for example, conducts in his center, to try to determine metabolism, pharmacologic action and side effects with increasing dose, but also, and that's a bit of a challenge, I would say, in the development of drugs for pain, early evidence of effectiveness of target engagement. Are we actually engaging and modulating a physiological process of interest, the one that we've identified in preclinical and animal studies? And in drug development, and it's not specific for the development of treatments for pain, there is this so-called, sometimes it's called the valley of death. It's this, the fact that here there is a lot of loss along the way, and so a lot of potential drug candidates are identified, but very little of them actually reach the stage of being commercialized and made available as treatments to treat pain. And so there is this option, and it has been somewhat successful for the development of other types of drug, that pharmacodynamic biomarkers can be a way to try to help us out of this valley of death. So this idea that we can use human pharmacodynamic biomarkers that signal whether or not at a given dose we have an effect on the target we are trying to target in humans, and which can thus help us maybe identify those compounds that are most likely that we should bring to later stages of drug development, and also for dosage selection. So what dose should we attempt later in clinical trials in patients? Regarding to what I just mentioned when I was introducing the talk, is that in healthy volunteer studies, one of the challenges is that the nociceptive system in a healthy volunteer is in a physiological state. It's not in the pathological state that is typically associated with clinical pain. I'm thinking of inflammatory pain, but I'm also thinking of lesion of the nervous system leading to neuropathic pain, and then mechanisms of sensitization that I will develop a bit later on. So for such phase 1 clinical trials in humans, there is definitely a potential interest for using pharmacodynamic biomarkers, but I think we then also need to couple them with experimental models to try to engage or mimic some aspects of the changes in nociceptive function associated with clinical pain. So if we look at different types of clinically relevant states related to clinical pain condition, we typically describe nociceptive pain. So nociceptive pain due to activation of nociceptors, but in clinical conditions, we typically also have tissue lesions. We have pathology that produce inflammation and induces functional changes, but also even structural changes at peripheral level, producing peripheral sensitization, meaning that the way the nociceptors will transduce, will be sensitive to nociceptive stimuli, will dramatically change in this context of peripheral sensitization. In addition, so that means we need, if we want to evaluate drug effects in healthy volunteer studies, we need experimental models that can mimic such aspects of inflammatory pain and peripheral sensitization. We know for quite some time now that simply sustained peripheral nociceptive input, so the fact that you activate nociceptors in a sustained fashion, induces functional and structural changes in the central nervous system, which have been very well described in animal models at the level of the first synaptic relay in the dorsal horn, which produces this enhanced synaptic transmission of nociceptive input, not only the synaptic transmission of nociceptive input from those fibers that you have sensitized because they have been exposed to a strong nociceptive stimulus, but also through various mechanisms which could involve glial cells or diffusion of substance will also sensitize the transmission of nociceptive input from other synapses. So this is what we call central sensitization. It's probably an important feature that is present in many clinical chronic pain conditions, like but not only, for example, persistent post-surgical pain. And so again, this means that if we want to have pharmacodynamic biomarkers to assess drug effects in healthy volunteer studies, you need to combine them also with experimental models of central sensitization. There is a specific case of neuropathic pain, which is a frequent cause of chronic pain, which is particularly also resistant to treatment. Neuropathic pain, where lesions or diseases of the somatosensory system induce additional functional structural changes that are responsible for the positive signs of neuropathic pain. Because typically a lesion or a disease of the somatosensory system, you would expect negative symptoms, reduced ability to perceive nociceptive or somatosensory stimuli. But in addition to that, such positive symptoms arise, which give rise to ongoing pain, which give rise to hyperalgesia, which give rise to allodynia. And these positive signs involve functional structural changes, for which, so ideally, we would need experimental models of neuropathic pain that we could use for healthy volunteer studies, but I would be tempted to say that currently there is in humans a lack of experimental models of neuropathic pain. Of course, in neuropathic pain, central sensitization is often also present, and for that we do have some models. So there are some aspects of neuropathic pain and its treatment that can be addressed by such models. So if we want to mimic some of these models, something that we can do experimentally and which is actually quite easy, I will actually provide you different ways of doing that. So you can experimentally induce primary and secondary hyperalgesia. And that has been done for a long time. And the easiest way is actually to produce a small skin lesion. So you can produce a small skin lesion, and Hardy already described that following a small burn lesion with a bit of light tissue damage, there is the lesion, then there is an area of inflammation. You can see that the skin becomes red, and you have what is referred to as primary hyperalgesia. And I'm citing here Hardy, hyperalgesia. Primary hyperalgesia is hyperalgesia associated with tissue damage and occurring at the site of tissue damage. And it is the result of local elaborations of agents which excite terminal pain endings. But what was also described at that time is that even beyond the area of the lesion, beyond the area of the flare, in skin that appears to be not affected by the lesion or the resulting inflammation, there is also an area of increased sensitivity, which is what is referred to as secondary hyperalgesia. And this secondary hyperalgesia already Hardy described, so as hyperalgesia associated with tissue damage but occurring in undamaged tissue adjacent and at some distance from the site of injury. So that's what I just said. And he proposed it is the result of a central excitatory state in a network of internodal neurons which intercalate the noxious impulses from visceral, deep somatic, and cutaneous tissues. So that is what we call central sensitization. And if I go back, this central sensitization has been related to what has been reported in animals, so this increased synaptic transmission at the level of the dorsal horn, but which might also involve higher order synapses. So if we look at the models that we have, that we want to combine with functional markers of nociception to use in pharmacodynamic studies, there are a number of experimental models, experimental approaches to try to mimic different aspects of what I just mentioned, so peripheral sensitization and central sensitization. So they all involve, to some extent, activation of nociceptors. It can be through the injection or the topical application of chemical irritants. I will detail some of them in a moment. It can be also injury models where we produce a controlled experimental injury. And it can be, I will discuss a bit, that also direct activation of nociceptors, so electrical activation, electrical stimulation of nociceptors to induce central sensitization. So there are about a bit more than a dozen human experimental models. And in a recent review of those different models, you can see here the number of studies that were included in this review, looking at those different models and the total number of participants. So you see some models have been used extensively and others have been used much less. So I will focus on the ones for which there is the most data, starting with capsaicin. Commonly used model is intradermal capsaicin, where we inject in the dermis a small amount of capsaicin, which will activate capsaicin-sensitive nociceptors, so nociceptors expressing the TRPV1, which can be activated by capsaicin. And so it's a slightly invasive technique because of the injection. It's a bit of a challenging technique because the limiting the injection to the dermis layer is actually quite challenging. There is a difficulty, for example, in a pharmacological study that you actually need to inject also a pharmacological compound, capsaicin, so it can make things a bit more challenging. But what is interesting is that it induces a secondary hyperalgesia due to central sensitization in almost all participants, which typically lasts about half an hour to 2 hours. So you have a window where you can probe the state of the nociceptive system, probe drug effects on the nociceptive system when it is in a central sensitized state. As an alternative that has been used also quite a lot is topical capsaicin. So simply putting capsaicin on the skin using different preparations, because actually one of the challenges is that there can be quite a lot of variability in the penetration of capsaicin within the skin. You can see here, this is an infrared recording. We've applied capsaicin on the forearm, and you can see how the skin becomes warmer because of the neurogenic inflammation produced by the topical capsaicin, which activates peptidergic nociceptors. So a topical capsaicin is non-invasive. It induces some amount of secondary hyperalgesia. It also induces peripheral sensitization due to the activation of TRPV1 nociceptors and actually also strong neurogenic inflammation. The effect is relatively short-lasting, and so sometimes topical capsaicin is also combined with heat as a model to have a more long-lasting window to test drug effects, for example, on nociceptive processing in a peripheral and central desensitized state. Another model that has been used quite extensively is UVB irradiation. So you can irradiate the skin with UVB. You can define the dose based on the minimal erythema dose to have a treatment that has similar effects across individuals independently of their skin. It's used really as a model to mimic inflammation-related hyperalgesia without ongoing pain. So what is interesting is that erythema develops and primary hyperalgesia develops quite systematically across participants about 6 hours after the irradiation, and then it lasts quite a long time, which again gives a window where you can test drug effects, especially if you're interested in drugs that could act on inflammatory pain. So it's a commonly used model of inflammatory pain in healthy human volunteers. Another approach that has been gaining quite a lot of interest over the past years and which we have been using more and more in our lab is a non-invasive technique. The other advantage is that you can deliver something that is very standardized across a participant, which is transcutaneous high-frequency electrical stimulation of the skin. And we are using this electrode, which was developed in Aalborg, which is a multi-pin electrode. So you see it has multiple pins. It's simply placed against the skin and then deliver high-frequency trains of electrical pulses at a relatively high intensity. And the pins allow to preferentially activate the skin nociceptors, which are located most superficial in the skin. You can see that when we apply here just 5 seconds of stimulation, so 5 trains, each lasting 1 second, 100 Hertz trains. So the total conditioning time does not take more than 5 seconds of stimulation. You can see that it produces actually a flare response. The skin becomes red after the stimulation. This is due to the activation of peptidergic afferents, which release substance P, for example, in the skin. But then what is quite striking is that with this high-frequency stimulation of the skin, there is a relatively long-lasting area of secondary mechanical hyperalgesia, increased sensitivity to pinprick stimuli, which develops around the electrode and expands far beyond the area that was stimulated, and which lasts actually for several hours. So you see, you can apply it at different sites, and you have again a window of about 2, 3, possibly 4 hours, where you can assess, for example, drug effects on nociceptive processing in here a centrally sensitized state. It's also an interesting model because there is no ongoing sensations during testing, and the peripheral sensitization and primary hyperalgesia is very short-lived. So you really have a window where you have central sensitization with secondary mechanical hyperalgesia, but no other confounding effects, which makes it an interesting model again to combine with pharmacodynamic biomarkers. A last model, very briefly to mention, is intracutaneous low-frequency stimulation, which is a minimally invasive technique. The original method described by Koppert early 2000 uses a thin stainless steel needle that is inserted intracutaneously, and then a continuous electrical stimulation is given at a relatively low frequency, 5 Hertz. Before I was mentioning 100 Hertz for high-frequency stimulation. And the current can be gradually increased. So again, it produces some amount of secondary hyperalgesia and an increased sensitivity to mechanical pinprick stimuli. It can also produce a flare response. It can also produce some amount of primary hyperalgesia. And what might be interesting also with this model is that the continuous stimulation that you keep over time, in some way it's what mimics the most. It's the only model that mimics to some extent what happens in peripheral neuropathic pain, where you have ectopic activity. Of course, here it's not spontaneous activity, it's stimulation-evoked activity, but it does mimic maybe some aspects of neuropathic pain. In this review paper, we also examined sensitivity to different drugs, and without getting into the details of that, if I take those 3 models here, for example, capsaicin and low-frequency stimulation of the skin, which are models that seem to be mainly related to central sensitization in terms of the changes they make, and UVB, which seems to be more a model of inflammatory pain, you can see the sensitivity to drugs, they have different patterns. So, for example, you see UVB here is quite sensitive to NSAIDs, while capsaicin LFS are more sensitive, for example, to gabapentin or pregabalin. So it seems that different models that we can use in healthy human volunteers do appear to some extent to differentially mimic different aspects of pathological pain or the mechanisms that you see in chronic pain conditions, and the different sensitivity to different drugs indicates that they could be of interest for pharmacological drug development. I've briefly introduced some, let's say, clinically relevant experimental models that we could use for early stage studies in healthy human volunteers, and these are actually models that, for example, Geert-Jan uses at CHDR. And they can then be combined with pharmacodynamic biomarkers. And we actually have an array of methods to non-invasively obtain either direct or indirect measures of nociceptive processing along the entire neuraxis, and I will illustrate a few of them. Measures of nociceptive processing at peripheral level, at spinal level, and at brain level, for example, using EEG. And so the idea is that some of them could be sensitive to drug effects on nociception, on nociceptive processing, and could thus be useful to characterize drug effects in humans. And for example, whether changes we can see in animal models translate to humans. And because there is the question of, yes, how does a mouse or a rat translate to humans? But there is also the method we use to assess nociception, which are very different in animal models and human models. And I think one of the efforts that should be done and is currently ongoing is to actually also try to better translate the methods we use to evaluate nociception in animal models and in humans. So if I go through a couple of them, so you have a bit an idea of the array of methods we can use. One method which actually is not so useful in healthy human volunteers is microneurography. Microneurography is a minimally invasive technique which involves inserting a thin needle in a nerve trunk to directly measure action potentials within single units. And for the nociceptive system, we can assess that in non-nociceptive C fibers. And what is most useful, microneurography is most useful in the context of neuropathic pain because you can characterize ectopic spontaneous discharges, which translates in what we call activity-dependent slowing, which is the fact that the nerve conduction velocity of C fibers will vary, will fluctuate over time because there is some spontaneous activity, and this spontaneous activity produces slowing within those C fibers. And so you can see here a typical example of the latency of the microneurographic response, which, if there was no spontaneous activity, would remain constant. And those fluctuations indicate that there is some amount of spontaneous activity. Here is an example of a drug study in a single patient, so suffering from small fiber neuropathy for a number of years, and then microneurography performed before and during treatment with lacosamide. You can see here the important amount of activity-dependent slowing, which disappears after the treatment. So an idea of how microneurography can show drug-induced effects in the nociceptive system at peripheral level. The thing is that in healthy human volunteers, there is no spontaneous ectopic activity, so microneurography would not be so useful in healthy human volunteer studies, but would be more interesting in focused studies conducted in well-characterized patients. Another approach that is being developed at peripheral level is nerve excitability testing, which is a non-invasive method which involves electrical stimulation of the nerve and measuring either sensory responses, so the sensory nerve action potential, or motor nerve responses. And the interesting aspect of this nerve excitability testing approach that was introduced by Hugh Bostock is that so there is an automatic adjustment of stimulation intensity, and then test pulses are combined with conditioning stimuli, or different test pulses are used, and from that several measures can be derived that are sensitive to different aspects of peripheral nerve excitability, so sensitive to membrane potential, nodal, internodal changes in membrane potential, and changes in the activation of ion channels and electrogenic ion pumps. So combined as a set of measures, it could be a very interesting way to assess drug effects on actually peripheral, all the factors that determine peripheral nerve excitability. Here you see an example in a drug study, again in patients here, in a group of patients with neuropathic pain treated with meloxicam. And you can see here two parameters of this nerve excitability testing that are clearly affected by the treatment. So again, a potential pharmacodynamic biomarker. A limitation of this nerve excitability testing is that the measurements that are made are only related to the activation of large diameter fibers. So motor fibers and large diameter fibers, so not nociceptive fibers. And so that's why the method is currently being adapted using a different type of stimulation electrode and no longer using electrophysiological responses, but actually perception. So subjects have to report whether or not they detect the stimulus. And so this could be an adaptation of nerve excitability testing that would actually allow to assess nerve excitability within small fibers, which could be pharmacodynamic biomarker for the drug development of treatments for pain. Spinal biomarkers, so the nociceptive withdrawal reflex is one way that we have in humans to actually assess some aspects of nociceptive processing at the level of the dorsal horn, at the level of the spinal cord. The technique is quite simple. It involves a noxious stimulus to trigger this spinal reflex and then of recording the muscular response which is triggered by the activation of that reflex. So it's a pure nociceptive reflex mediated by dorsal horn circuitry. And you can see here an old study by Jean-Claude Willer showing the effect here of morphine on this nociceptive reflex. So again, so you can see drug effects at the level of the spinal cord. And then the spinal reflex, it's a spinal reflex, but it's also strongly dependent on descending influences, of course, including cognitive factors may modulate that reflex. So you can see here, for example, this is another aspect of the reflex, the R3 area, but you can see how the reflex is increased when subjects focus their attention on the noxious stimulus. So cognitive factors can modulate also spinal biomarkers such as the nociceptive withdrawal reflex. Another biomarker that is being proposed, there have been a couple of studies suggesting that it could be of interest, is the cervical component of upper limb somatosensory evoked potentials, which has been described for already many years. You see here an early latency when we stimulate the median nerve. It appears about 13 milliseconds after stimulation of the median nerve. It can be recorded non-invasively by placing an electrode here on the neck. You can use different electrode locations. And considering 13 milliseconds, of course, that's very short. So 13 milliseconds, this is not a response that is triggered by nociceptive input. It's the response of dorsal horn neurons to noxious inputs. But what's interesting is that there are elements, and there is data suggesting that even though the response itself is not triggered by nociceptive input, it might be sensitive to changes in dorsal horn excitability that are also related to the development of central sensitization and to sensitization of the transmission of nociceptive input at the dorsal horn level, suggesting that it could be used as a biomarker of central sensitization in human studies. So in this recent study, we induced secondary hyperalgesia and central sensitization using capsaicin, topical capsaicin applied on the hand here. And then we recorded this N13 somatosensory evoked potential by stimulating the non-sensitized upper limb and the contralateral, the sensitized upper limb. And you can see here this small enhancement of the N13 that is observed for stimuli after the induction of central sensitization and present only when we stimulate the sensitized hand. What was also interesting is that when this study was done in subjects that were treated with placebo or treated with pregabalin, you can see that patients, subjects, healthy volunteers treated with placebo, there was this increase in secondary hyperalgesia. After capsaicin, there was the increase of the N13, so which followed this secondary hyperalgesia. And both the secondary hyperalgesia induced by capsaicin and the increase in the N13 amplitude was not present in subjects treated with pregabalin. So this is really an example of how pharmacodynamic biomarkers combined with a method to mimic the changes that might occur in patients that have clinical chronic pain, for example here due to central sensitization, could be useful for drug development. If I move now to brain biomarkers, there are actually many different approaches that can be done. There are some approaches that are more based on the recording of spontaneous brain activity and looking at changes, not stimulus-evoked responses, but changes, for example, in the spectral content of the electroencephalogram, changes in the basal activity or connectivity across brain regions using functional MRI. And then there are approaches that are based more on stimulus-evoked brain activity, where we apply a stimulus, we record the brain response to that stimulus, and we try to use this as a measure of nociceptive processing, which in that case will then be sensitive actually to any drug effect along the entire neuraxis. So if I apply a drug that has a peripheral effect, this is obviously going to affect my brain response to a stimulus. So it's important to bear in mind that brain biomarkers are not only sensitive to effects occurring at brain level, but they will be dependent on everything that leads to eventually triggering that brain response. So for the sake of time, I will focus only on event-related brain potentials that can be sampled using EEG combined with a sensory stimulus. So one technique that is probably the most used technique is the recording of laser-evoked brain potentials, which allow, without any contact of the skin, to selectively activate heat-sensitive nociceptors in a very phasic fashion and produce a laser-evoked or heat-evoked brain potential whose magnitude, whose latency will be dependent on the functional state of the nociceptive system. Here just an illustration of how this can be used as a potential pharmacodynamic biomarker. So you can see in this study, single dose of tramadol versus placebo, how it differentially affects the magnitude of the laser-evoked brain potential. So again, showing its potential use as a pharmacodynamic biomarker. Manipulating infrared lasers is a bit challenging. There are also risks, accidental eye lesions, for example. So it's probably one of the reasons why you don't have many of them in many clinical centers, and it's definitely not entered clinical routine. Since 2 or 3, 4 years now, contact heat evoked potentials has greatly improved with new probes that are able to do very steep heating ramps. And so you can see that you can get responses to contact heat that are now very similar to those of infrared laser stimulation, which was not the case with the older thermodes. And so this is really changing, I think, simplifying and opening up easy opportunities to accept nociceptive processing using contact heat and also contact cold, which is interesting also considering that some changes, some pathological changes in the nociceptive system may differentially affect how we respond to heat or to cold stimuli, for example. Another method that we have been developing, not only us, also in Germany, is a mechanical pinprick stimulation. So I was mentioning central sensitization, secondary hyperalgesia. This secondary hyperalgesia, the key feature is an increased sensitivity to mechanical pinprick stimuli with little or no changes in heat sensitivity. And so that's one of the interests of combining different types of nociceptive stimuli, because the changes in the nociceptive system can lead to differential changes in how we respond to different types of nociceptive stimuli. So mechanical pinprick stimulation, a tip with a weight, can be used as an easy way to deliver calibrated mechanical pinprick stimuli. You can see here, before and after the induction of central sensitization using high-frequency electrical stimulation of the skin. You can see at the sensitized arm, you can see here after the induction of sensitization, the clear increase in the response. So again, a possible marker of central sensitization that we can use in human volunteers. And just to highlight again what I just mentioned, the interest of combining different types of stimuli, you can see that if at the same time we also measure heat-evoked brain potentials, you see that those are not affected, even though they are delivered to the same area. One of the difficulties with mechanical pinprick stimulation is how to deliver the stimulus in a standardized fashion and that is not operator dependent, and also where we have a clear phasic stimulus. So we have developed this sort of sewing machine which instead of the operator holds the stimulator and allows us to deliver a calibrated and better controlled stimuli, and you can see that this produces responses that have a higher signal to noise ratio. So it's relatively simple improvements, but that can actually make it from something that might be possible into something that is actually useful potentially in drug studies. Now, if I move on, and the later parts are a bit shorter because actually I will be talking about the same methods to evaluate nociceptive processing, but I will be looking at different applications instead. So if we look now at the potential use of biomarkers for clinical diagnosis and personalized medicine, well, the first thing I need to say is for neuropathic pain, in a way it's already established. So neuropathic pain is defined as pain caused by a lesion or disease of the somatosensory nervous system. So it requires actually to demonstrate this loss of function, the consequence of this lesion or disease of the somatosensory nervous system that is going to lead to sensory loss and reduced ability to respond to a nociceptive stimulus. And so that's why if we look at the current guidelines for the evaluation of neuropathic pain, laser-evoked potentials, as I mentioned, are established as useful for assessing function of the A-delta fiber subcortical pathways in patients with neuropathic pain, so for the diagnosis of neuropathic pain, because reduced, altered lesions of the somatosensory system affecting small fibers will alter those laser-evoked potentials. And so that's why they are actually used in many clinical centers for the actual diagnosis of neuropathic pain. Yes, maybe for the sake of time, I will skip that one. Yes. And then there is also this notion that we should try to move towards mechanism-based diagnosis. So if we look at the positive signs, or if we look at patients with chronic pain, we know there are a myriad of different mechanisms that can contribute to this chronic pain condition, and they might be quite different from one patient to the other, or from one patient group to another patient group. And so there is this idea that mechanism-based diagnosis, if we could have biomarkers that are sensitive to the different changes due to different mechanisms that occur in those patients, we might be able to better select which patients should be treated with which treatment and to predict a response to treatment. So it's really a bit later part. It could also be, of course, of interest for patient selection in drug studies. Do we want to do clinical trials in patients? Do we want to pre-select patients, to stratify patients that we include in those clinical trials? Related to this, I think what's currently for which there is the most evidence that it can be an approach is what we call irritable nociceptor phenotype. So this is based on what we call quantitative sensory testing, so assessing various changes in sensitivity to different types of stimuli, nociceptive stimuli, tactile stimuli. So using an array of sensory stimuli, we can try to assess the sensory phenotype of each patient. And one of these phenotypes that has been proposed is what we call the irritable nociceptor phenotype, which includes positive signs, so signs that you are actually more sensitive to some types of stimuli as compared to healthy participants. So the presence of dynamic mechanical allodynia, or reduced mechanical or pressure thresholds, or increased mechanical pain sensitivity, or reduced cold or heat pain thresholds. And in this study, they included 97 patients with peripheral neuropathic pain, and they were treated with oscarbazepine or placebo in a clinical study. The peripheral neuropathic pain was of different origin: polyneuropathy, surgical, traumatic nerve injury, post-herpetic neuralgia. And of those 97 patients, 31 had the phenotype irritable nociceptor phenotype. And you can see that the patients with the irritable nociceptor phenotype, you can see that the change in pain following treatment with oxcarbazepine as compared to placebo was clearly stronger than in patients with the non-irritable nociceptor phenotype. So indicating if we imagine that this irritable nociceptor phenotype have increased peripheral nerve excitability, that this is what is actually producing this phenotype, you can see how we can slowly maybe go towards mechanism-based or phenotype-based diagnosis and indications for treatment. Another potential approach, or something that is of interest, is related to central sensitization, which is produced by anyone exposed to sustained nociceptive input will develop central sensitization. Maybe some develop stronger central sensitization, which does not revert, which remains over time. This can also happen in neuropathic pain conditions. It's also thought that central sensitization might contribute to some chronic pain conditions such as fibromyalgia possibly, or painful temporomandibular disorders, chronic low back pain for sure. And so in this recent study, we examined the susceptibility to develop central sensitization in patients. So these were patients that have painful temporomandibular disorder, and we apply high-frequency electrical stimulation on the skin of their forearm, and we characterize the increase in mechanical pinprick sensitivity they develop 20-45 minutes after HFS. And you can see that patients with temporomandibular disorder have an increased area of secondary hyperalgesia as compared to healthy controls. And you can also see that in this preliminary study, you can see that there is also a lot more variability in the TMD group. So what we are interested in, what we would like to look into now, is whether there might be subgroups, some patients with painful TMD that have an increased susceptibility to develop central sensitization and maybe others not, and maybe they would respond differently to different treatments. And you can see that those TMD patients also had stronger HFS-induced allodynia, so indicating that there was also changes here related to allodynia. And so in the QS Pain Relief study, the work package 8 of the QS Pain Relief study, it's exactly a bit towards those things that we are trying to do. What we are trying to do here is in patients treated for persistent post-surgical pain to measure some of the biomarkers I mentioned. So here in patients, not in healthy volunteers, before they start a treatment, some days after they have started a treatment, in this case here a combination treatment, and to assess the changes in the biomarkers with the actual clinical outcomes, so the patient-reported outcomes that are actually reported by the patients, to see whether some of the drug-induced changes in those biomarkers might predict clinical efficacy, and so trying to, again, move a bit further in the direction of predicting response to treatment. In the last few minutes, preventing chronic pain. So to prevent the development of chronic pain is, for example, to try to prevent the development of neuropathic pain. So in diseases that evolve over time and where we know that there is a risk of developing small fiber neuropathy, like in diabetes, for example, some biomarkers could be used to identify patients at risk of developing small fiber neuropathy or that might have subclinical small fiber neuropathy, and for which there might be a potential interest in introducing preventive treatments to try to, specifically in those patients, try to reduce, to slow down the evolution towards small fiber neuropathy. Some years ago, and we've taken this over now more recently, but using psychophysics and cold stimulation with the contact thermo that we have used, we are comparing healthy controls, type 1 and type 2 diabetic patients that have no clinical signs of neuropathy. And you can see that their laser-evoked brain potentials are on average reduced as compared to healthy controls, despite the fact that they don't have any obvious clinical symptoms. And using very simple psychophysics to assess the ability to detect transient cold stimuli, you can see that we are also able to accurately distinguish healthy age-matched controls versus type 2 diabetes patients that do not have any clinical symptoms. They have a normal neurological examination, but they do have reduced sensitivity to cold stimuli. So that's, I think, a potential also for biomarkers based on responses to nociceptive stimuli or related to nociceptive processing. And maybe one last thing to open is susceptibility to develop pain or sensitivity, individual differences in the sensitivity to pain. There have been over the last years quite a number of studies that have looked at changes variations in the electroencephalogram that might be predictive of the sensitivity to perceived pain. And there have been a number of studies conducted in healthy volunteers where the electroencephalogram is measured in a pain-free state in a healthy volunteer, okay? And then they apply an experimental pain procedure using different approaches for more transient pain or more sustained pain over several days. And most of these studies conducted in healthy human volunteers have shown that the peak frequency of the alpha band rhythm. So the alpha band rhythm is the prominent rhythm in resting awake EEG, typically between 8 and 12 hertz. And some people will have alpha rhythm which is a bit faster, others will be a bit slower. And what they found is that in healthy volunteers, subjects that tended to have a slower alpha also tended to report the intensity of the pain induced by the experimental procedures as stronger. So there seems to be a link between slowing or slower alpha and increased sensitivity to pain. And in studies in patients with chronic pain, they also have a tendency to have a slower alpha as compared to age-matched healthy controls. And it was not known, is this a consequence of chronic pain, or is it because they have an increased susceptibility to develop chronic pain that on average they have a slower alpha. In this proof of concept study, I think actually we started at the same time, but so in this very recent publication, this was a pilot study conducted in 16 patients undergoing surgery, thoracotomy for lung cancer. And they median split their group, very small group, 16 patients. So they ended up with 7 patients with the high pain group, 7 patients with the low pain group, depending on how intense and they reported their post-operative pain during the days that followed the surgery. But you can see that in the high pain group, the alpha frequency tended to be slower than the low pain group. So suggesting that there are preoperative factors, some of which can lead to changes that you can measure in the ongoing EEG that can predict to some extent how pain will be perceived, the susceptibility to pain. And in parallel, we actually had started doing the same thing. Our study is still ongoing. We collected data in 116 pain-free patients, planned for a median sternotomy. And again, we assessed here the peak alpha frequency of our patients based on an EEG recording performed the day before the surgery. If we look at the peak alpha frequency, so the frequency at which alpha is present in patients that report persistent pain versus do not report persistent pain 3 months after surgery, we were interested more in the development of persistent post-surgical pain. You can see that basically there is no difference in the peak alpha frequency between patients that report persistent post-surgical pain at 3 months after surgery versus patients that do not report it. But if we look now with those patients that do have persistent post-surgical pain at 3 months, we look at the relationship between the alpha rhythm and the severity of that persistent post-surgical pain, then with the data that we currently have, we do see at least a trend again towards stronger persistent post-surgical pain in patients that have a slower alpha rhythm as compared to subjects that have a higher alpha rhythm. But of course, this is preliminary data and we are still collecting data to get a better understanding of this relationship. And the last point, and this is an ongoing study, so I do not have yet results to report, but again, susceptibility to develop central sensitization, for example, following surgery. It is known for quite some time that one of the factors that predict the development of persistent post-surgical pain is the presence of secondary mechanical hyperalgesia in the days that follow the surgery, so that you have this increased sensitivity to mechanical pinpricks stimuli, which is indicating that the procedure has induced a central sensitization producing this secondary mechanical hyperalgesia. This is something that is predictive of the development of persistent post-surgical pain. And so we are conducting a study which was, as other studies, as you know, severely impacted by the COVID pandemic, but we have an ongoing clinical study where we are evaluating whether the preoperative susceptibility to develop secondary mechanical hyperalgesia using our controlled high-frequency electrical stimulation of the skin, whether it predicts the severity of acute post-surgical pain and the subsequent development of persistent post-surgical pain. So some patients might have an increased susceptibility to develop central sensitization, which puts them at risk of developing persistent post-surgical pain. And I think with that, I am finished. Thank you for your attention.